Good morning, everyone. I'm Dr. Vijayshree Patil. I'm in charge of the Pain and Palliative Care Department at HMCI. Uh, I'm sorry, I thought everybody would be here, but I'm not sure who is present right now. I can see Sir, but I'm not sure who else is there. So, anyway, good morning to everybody. Today, we're talking about the role of palliative care in head and neck cancer. I hope I'm audible. Yeah, right?
Yes, yes, you are audible.
Okay,
Please
thank you.
go ahead. Please go ahead.
Thank you. All right. So, we're talking about the role of palliative care in head and neck cancer. Before we get into specifics, I just wanted to update everybody on the concept of palliative care in general. So, among the Southeast Asian region countries, as we know, the highest need for palliative care was perceived in India and China. And as per a study done in 2021, in India, we have 1 million new cancer cases that are diagnosed every year. There are 4 million patients, both cancer and non cancer, who need palliative care annually, and less than 4% of those people actually receive or have access to essential pain and symptom relief measures in palliative care. Point to be noted also that out of those 4%, 80% are in Kerala, in just one state, which has got a state run palliative care program. The rest of the country has even less than that. 20% is in the rest of the country, and 80% of that 4% is concentrated in Kerala itself. About 0.4 to 1% of the population in India needing strong painkillers like morphine for uncontrolled pain actually receives it. This is something we also evidence in a lot of our patients that come from UP, Jharkhand, Chhattisgarh, Bihar, where morphine is absolutely not available. Even going to a place like Tata Banaras, which of course has a long waiting period and things like that, even for their palliative care department, that's the only place that will give you morphine on demand after seeing our papers. The other places, it is very, very difficult for them to procure the drug. A lot of them, in fact, come back to us once a month just to take that stock from us. Annual palliative care need in India is estimated to be around 5 million, and at present, less than 5% of them are receiving palliative care. So, what is palliative care? By definition, palliative care is an approach that improves the quality of life of patients and their families. We talk a lot about caregivers also. I'll elaborate on that as we go ahead. Facing problems associated with life threatening illness through the prevention and relief of suffering by means of early identification, impeccable assessment, and treatment of pain and other problems, physical, psychosocial, and spiritual. So, what does that mean exactly? We have a small video to just elaborate on this. Can we hear it? Can they hear me? I'm not sure if you could hear the audio.
No audio was heard.
All right, sir.
The
So I
visual was good, but audio was not heard.
So I'll just elaborate that palliative care is like a bridge. Like you saw the gentleman sitting on a bridge, sometimes your body starts crumbling. So we are the support that comes from below to reinforce the bridge of care, which includes everybody else also in the team. Palliative care is always given by a multidisciplinary care team. Moving on. We have doctors, we have nurses, psychologists, social workers, pharmacists, nutritionists, the caregivers, of course. You could also have spiritual advisors, community health workers. Everybody works together to give very holistic care and compassionate care to the patient. Yeah. So, who can benefit from palliative care? A lot of times what we realize, especially when I started shifting into palliative care from critical care, is that most people believed palliative care was only end of life or the last days or hours of care, but that's not what we entail in palliation. We also include early symptom management. We also talk of symptomatic burden relief, so optimizing quality of life, using a palliative approach for life limiting illness, maximizing your community supports, giving support to the family of the patients who are also suffering, caregiver distress burden, advanced care planning, very, very important in patients with chronic illnesses, end stage cancer also. Breaking that news to them that, okay, this is the end of the line, we can't treat. Henceforth, we have to live with whatever disease we have. But how do we give you a good quality of life? Preparing them in that scenario. All of this also entails palliative care. End of life care may not always be just a few hours or days before the death of the patient. That is what we call last days or last care. End of life care could be 6 months when the patient comes and asks us, how long do I have? We say 6 months, okay, there's nothing more treatment that wise that we can do, nothing to cure the disease. Now we only palliate. So end of life care could range anything to weeks to months to sometimes even a whole year. In that period, how do we reduce their suffering? How do we increase their support? Can we offer them respite care, symptomatic care, caregiver relief, or even direct them to a hospice? Like in Bombay, we have Shanti Avedna, which looks at only the end stage care. So could we, direct them to resources like that? All of that comes under end of life care. But palliative care, when does one initiate it? We believe that palliative care can be initiated right at diagnosis. So, if we look at the disease progression, when we talk of prevention, you have at diagnosis, you have curative and palliative care, both that can go hand in hand. Curative, of course, is what everybody here is doing surgical, radiotherapy, chemotherapy, all of these measures can be taken. Symptomatic, supportive care, prevention of complications, just preparing them, keeping them one step ahead of things that could go wrong. Even the awareness that, simple chemotherapy could cause hair loss, even anticipating that is better than, getting a surprise. So that is what our team does. A lot of times when you see our nurses, our psychologists on rounds, a lot of times we are just telling them, "Oh, okay, this might happen, you might feel nauseous, you might get loose motions, you might lose your hair, you might have pain, we'll help you through it. But don't be worried if you see any of these symptoms." That itself looks at, a very holistic approach towards taking care of our patients, which then progresses into, as the disease advances, progresses into end of life care, hospice care, death, as the and when the death occurs, caring for the patient and the family at that point. And my something that I personally encourage and look into is bereavement support after the patient has passed away. Grief counseling, caring for the relatives, caring for the caregivers, the primary caregivers who go through so much. So our team also does bereavement follow-ups for the patient. I'll elaborate on that as we go ahead. But these are the types of palliative care that can be initiated at different stages of the illness. So, unlike a very popular conception that palliative care is entails only end of life care, we believe that palliative care can also be initiated at diagnosis and be a more holistic form of care. So, role of palliative care in head and neck cancer. Coming to specifics, before we talk of purely palliative care, we also have palliation that we are doing in our different departments. So you do palliative surgeries, you do palliative chemotherapy, you do palliative radiotherapy, where the intent of your treatment is not curing the patient. The intent is improving their quality of life and reducing their symptom burden. For example, palliative surgery would be a divergent colostomy, a tracheostomy in case of airway obstruction, where you're not really curing the disease. Palliative chemotherapy that is given to reduce symptom burden. Palliative radiation, where we look at pain management, especially for bone meds, spinal meds, where it may give you pain relief, but not really cure the cancer per se. So we are palliating patients in our respective fields also. So what do we do differently? We primarily look at the symptom burden. Symptom burden, in the sense, of course, pain is a very, very major symptom that our referrals come to us for. Pain may be somatic, visceral, neuropathic. We follow the WHO analgesic ladder, step ladder pattern for management of pain. Another very, very common symptom that patients come to us early for is dysphagia. Around 40% of head and neck cancer patients do have dysphagia, which may result in aspiration also. Their appetite goes down, anorexia is seen, mucositis, nausea, vomiting, constipation. A lot of them have constipation, secretions. Uh, Very, very commonly for pain, we give them opioids. At the same time, somebody has already prescribed glycopyrrolate or hyoscine. So very commonly, glycopyrrolate is given for secretions, and that causes together decreased intestinal motility, which gives them very, very, very severe constipation to the point that they require enemas every other day. So, a little bit of understanding of pharmacology would just reduce that symptom burden sometimes, and we just, help them through that. Anxiety versus agitation delirium. So, you patients, of course, with cancer would have anxiety, which is taken care of with our psychological counseling. Sometimes they may require a psychiatrist or some kind of medication to deal with if it is really, really bad, clinically severe. But understanding the difference between anxiety and delirium or agitation, we have to remember head and neck cancer, one of the first things to hit the patient, which goes very unnoticed, is nutrition. They are very, very chronically nutritionally depleted, dehydrated patients. So, and particularly as they go through the grind of chemotherapy or surgery or radiation, they become more and more depleted. Towards the end, we see a lot of them getting aggressive. Sometimes they are just confused. There is a very big difference between a patient being anxious versus, like, for example, we had a patient who just came and started screaming and shouting. Later on, we looked at his electrolytes, we looked at his severity. He was in sepsis, which gave him a metabolic syndrome, which then caused him to be in agitation. Once it was cured, he was much better. So, understanding the difference between agitation, delirium versus anxiety. One would probably get better with just counseling, one would require us to investigate and look at it differently. We also have a lot of patients with METs, with metastasis, paraneoplastic syndromes, complications of long term use of steroids. We do give steroids very commonly to our patients. They may come with an increase in their blood sugar levels. They could have fractures because of reduction in bone density. So, looking at it more holistically, makes a lot of difference. Mobility. A lot of patients, one of the primary complaints they come to us with is, or requests rather, is that even if I'm dying, I want to be able to go to the washroom myself. So, trying and helping them do that is a very, very important part of what we do, because it's a sense of independence that we are giving them. It's a sense of autonomy over their body, over their illness. So, mobility is very, very important. And as and how it decreases, because towards the end, they will be bedbound. The counseling, if we have a few months in hand, just explaining to them, getting them to accept their situation over time, not immediately, over time, it makes a very, very big difference in reducing their symptom burden. Now, when we say pain management, we have what we call physical pain, and then what we in palliative care call total pain. So, of course, for physical pain, we all know the WHO analgesic step ladder that we use. Step one, we use non opioids and adjuvants, usually a simple NSAID like paracetamol or any other NSAID that we use, plus or minus any adjuvants. Second is a weak opioid. Please remember tramadol, buvilar, buprenorphine that we are using, or tapentadol are all weak opioids for mild to moderate pain that is used in step two with non-opioids with adjuvants. Each of them has a different mechanism of pain. Perhaps if I'm not focusing on pain too much today. Perhaps if we have another lecture, I'd love to elaborate more on different types of pain and why we need an opioid, a non-opioid, and an adjuvant together. Step three would be strong opioids, which would entail in India, we have morphine and we have fentanyl. So those would be for moderate to severe pain on a numerical scale rating of 7 to 10, plus non-opioids. So if you see any of our prescriptions, they would have morphine, they would have paracetamol, they would have an adjuvant for neuropathic pain like pregabalin, gabapentin, tryptamol. So that would be step three pain. Usually when the patients are referred to us, they are at step three, which is why they are on high opioids, strong opioids, because they come to us with a pain of never less than 8, right? So we give them a combination therapy. Step four, which was included most recently, also includes minimally invasive treatment. So we do look at blocks. We do look at certain other measures that could be used, but we don't really practice them here too much. We are focusing more on pharmacological methods. They are cheaper. They are more cost effective. We could later on perhaps look at neurological nerve blocks as and how the department expands. Now I want to introduce you all to the concept of total pain. Pain is very perceptive. It depends on the patient. If the patient comes and tells me he or she is feeling 8 on 10 pain as per the numerical scale rating, I can look at him and say, okay, your disease actually probably should have pain of only say 5 by 10. But you are telling me it's 8 by 10. Why does that happen? Because pain can be physical, like we all know, and we all treat pharmacologically. That pain, we understand from our experience that, okay, this disease should cause so much pain, this disease should cause more pain, or whatever it is. But the patient's perception of pain also depends on these other three factors. So there could be psychological factors, there could be spiritual factors, there could be social factors. How does cancer, especially head and neck cancer, fit into this total pain? The cancer per se would have pain, yes, physical pain induced by the cancer, physical pain caused perhaps by treatment modalities that they are on. They could have comorbid causes, they could have an infection. Sometimes their wounds are so fungating, so infected because of poor hygiene and not knowing how to treat the wound. They may have, they may get septic, which will increase the pain. But at the same time, if I am already anxious, if I am already suffering because of whatever other reasons, apart from the cancer, the fear of cancer, the fear of impending doom, of course, is there. But your anxiety, your depression, your past experience, if it's a recurrent cancer, could compound the pain and make it worse. So, what we expect as doctors to be a 4 by 10 or a 5 by 10 pain could go up to a 7 by 10. If I have social issues, which is very, very important in head and neck cancer, which causes severe disfigurement to the patients, there's a loss of role, social status. People don't want to go to work. We had a taxi driver who was operated, and had a disfigurement, and he used to cover his face up. He refused to have a rice tube for enteral feeding because he said, I'm already so disfigured, nobody will come and sit in my taxi. So till he was bedridden, he wanted to continue driving because that was the only income for his family. But then eventually he couldn't. And that was such a big fear in his mind that I can't do this because people will not come and sit in my, taxi and I will lose my job. That fear was causing his pain to, increase exponentially. financial concerns, worries about the future of the family. Head and neck cancer, again, tobacco chewing is a very, very major cause. Most of our patients are young adult males who are usually the only earning member of the family. The families are big, there are young children, wives may be dependent on them. All of these factors become very, very important in compounding pain and perceiving pain. Spiritual factors, there's a loss of faith, there is a fear of unknown. Patients usually ask, why is this happening to me? मैंने तो किसी का बुरा नहीं किया, मैंने तो सब अच्छा ही किया है मेरे लाइफ में. I have not done anything wrong, I did everything by the book, and this is still happening to me. So spiritual issues do come up, especially by the time they are reaching us, by the time they are at the end of the fag end of their treatment plans. So all of these factors compound the perception of me. So again, like what I said, if the pain is expected by me as a physician to be at 4/10, the patient may come and tell me that your pain is actually his pain is actually 9/10. So do I then use only pharmacological methods? I might overdose him. So I have to have a very holistic talk. So our first visit has to be, to understand from a psychological point of view, from a social point of view. So we look at all of these factors and then prescribe a treatment plan or a plan of care. We start counseling them right from the beginning as to what they would expect. We break bad news to them in a very, very specific, protocolized way to help them overcome this total pain that they are going through. Now, again, coming back to role of palliative care in head and neck cancer, this is the other part, not just the symptom burden, holistic, psychosocial, and complementary issues. After speaking about total pain now, I think we'll be able to appreciate these better. So, breaking bad news to the patient. The first time you're telling a patient that, okay, this is it, there is no more treatment, you have to take your patient home if they've come from out of town, or this is it, you just have to now deal with it and wait for the end. It's a very difficult thing for people to digest. That's a very difficult thing for people to understand and wrap their head around, because they've come to us with a lot of hope. They usually want to get better, they have that hope, they're young patients. So breaking bad news is a very, very important part of our care plan. Helping them understand, we use something called a spikes protocol, which I'll elaborate later. The patients themselves, young patients, have aspirations, expectations. They have young children, they want to see them grow. If the patients are in their teens, in their 20s, they want to do certain things. They want to buy a house, they want to have a job, they want to get married. They may not be able to do all of these things. So, how do we help them with this burden? Anxiety and grief burden, helping them with counseling right from the beginning. Like I said, initiate palliative care at diagnosis so we prepare them better. Psychological support, emotional support. We also look at support groups for caregivers and for patients. Many patients going through the same illness sometimes find support in community. Many caregivers, this is something that I'm very passionate about. Again, caregiver distress. A lot of caregivers, and I used to see this when I was in my critical care days. We used to have all the caregivers of the patients who were in the ICU would be sitting outside, and they would be supporting each other emotionally. So that's where I got this concept from, and this is why we have support groups for caregivers. Young wives, mothers, children, we create separate groups for them and have counseling sessions together. Sometimes they end up supporting each other better than even we could, because they actually understand the situation that they are in. We can only empathize. We also look at alternative therapies like massage therapy. Aromatherapy is coming up in a very big way, especially for head and neck cancer, because malodor is a very, very important symptom, especially with large fungating wounds. People don't want to go in social settings. People don't want to, have people over to their house because of the odor. They get socially isolated. So having aromatherapy in the form of, perfumes or scents which are not toxic, which have they don't have hormonal disruptors. This is coming up in a very big way, and we are tying up with a company that looks at aromatherapy in this way also. Now, end of life care. This, of course, is something that is synonymous with palliative care. I don't know how many of you knew that we do all of these other things apart from end of life care also. So how people die remains on in the memories of those who live on. And that is probably the most important thing for us. And that's why we look at caregiver distress and support also in such a big way. So there is an end of life care policy for the dying consensus position statement of the Indian Association of Palliative Care, which is a very, very important landmark paper. And I'm proud to say a lot of these people who have written the paper, I'm proud to call them my mentors in palliative care. So I'll be referring to this paper for the slides on end of care policies. So how do we recognize a dying patient? We all know the signs more or less. I'm just running through them. You would have progressively falling blood pressure. You would have progressively falling body temperature, cooler hands and feet compared to the rest of the body, altered breathing. They will not be breathing like they normally breathe. Okay. Skin color would be duller. There would be mottling, bluish nails, bedridden patient with decreased spontaneous movement. Patient would cease to respond to questions. There may not be any spontaneous verbalization. There would be detachment from surroundings, no interest in food, water at all. Bedridden patient with diminishing spontaneous movement. Patient could be in a comatose state, unable to take any medication or disinterested to feed orally. Patient may have severe cachexia. Now, decision making. This is very, very important for us. We have to have open, honest communication, shared decision making, and smooth transition of the care process required to facilitate the process. The patient is going to die. We are all going to die. I know it's a very morbid thought to have on a Monday morning at the beginning of the week. I'm sorry. But the fact is that the patients are at some point going to pass away. How can we make this better for them? How can we make this better for the caregivers? Both are our patients, and it's important equally for them because, like we said, how the patient is dying stays in the minds of those who live on. So we don't want to traumatize them either. Everybody, it has to be a good situation for everybody. How is death good? Is the next question I always get. This is a very morbid thing. We are taught since we are children that death is the worst thing that's going to happen to you. So how do we make it better? Key end of life communication should include prognostication, discussion on resuscitation, advanced care planning, and end of life symptoms. Prognostication, a lot of times, now the major limitation, of course, is the patient always asks you, how much time do I have? We give a ballpark figure. We say 6 months, we say 3 months, we say few days. Few days, we can usually say that, yeah, okay, this is a bad situation, it's easier. But when we tell a patient, okay, there's no more treatment option, how much time do I have? It's very rough. You can't really prognosticate the time. And that's the most important thing they want. So, best estimates still have a degree of uncertainty. But discussion on resuscitation, discussion on advanced care planning, and discussion on end of life symptoms is something that we know and we can offer them. Should a patient with metastatic lung cancer, brain mets, whatever, all of these, significant end stage 4 disease, should they be resuscitated? In case there is a code blue in the ward, should you have a resuscitation for this patient? Is it going to make any difference? We want them to die in peace, but protocol would dictate that if there's a code blue, legally, I have to resuscitate the patient. So don't you think it's important to have an open and honest conversation with the patient that, okay, this may happen to you. Would you like to be resuscitated? Because you tell them honestly that it's not going to make a difference. Very genuinely. You could be on a ventilator and then just be on a ventilator. Imagine the physical symptom burden, of course, but also the financial resources that get drained in these processes. Advanced care planning, I'll come to that again. So, end of life palliative care, the guiding principles would include symptomatic relief. Now, what is symptomatic relief in end of life when the patient is absolutely dying? You want them to be pain free. Very, very important. Keep them pain free. We give them good narcotic medication. We also look at something called terminal sedation. You could have dyspnea. Patients, the relatives never want to see the patient gasping. That is very important. Narcotics also cause a certain level of respiratory depression. So if they are already on those medications for pain, they should not be gasping desperately with air hunger. Okay. Delirium, respiratory secretions. We have something called a death rattle, where there are so many secretions, especially in head and neck cancer. There are so many secretions, there's so much pooling that there's a rattling sound that comes, which is very scary for the patient and for the relatives. So we try and explain suctioning to them, or at that point, look at options like glycopyrrolate, iocine, review of the treatment plan, and stopping unnecessary medications and investigations that do not help the current process. Okay, so we completely eliminate medications that are not going to. Patient is thinking, don't unnecessarily force just because there's a rice tube or a peg tube in place. We don't just keep, giving them these medications or continuing with investigations. Just let them be. Counseling regarding optimal hydration and food intake. Now there are a lot of religions or cultures that say that patient को कुछ तो खाना चाहिए या पानी तो देना चाहिए. I can't let my patient starve. Patient is dying, okay, but I don't want them to starve. Versus certain religions that say that patient is anyway going, why should I nourish a dying body? So Jains believe in that very strongly. So they never opt for things like rice tube. A lot of them, if they are very religious, they would say no. We don't want a rice tube. We don't want a peg tube. Let the body just take its natural course and go. Whereas there are certain, like Indians, culturally, food is so important to us. Food and water is so important to us that I want to feed my patient. Kuch to main khilao. So that is a discussion again we start having when they come to our OPD itself. That someday you may need a rice tube. Would you want one? Would you not want one? The earlier you have these discussions, you'll always have initial resistance from the patient for whatever reason, social, disfigurement, having a tube, care for the tube, all of those things. But at least give them time to decide. They have a sense of autonomy. They also understand the pros and cons. They have enough time to figure out what they want, and then they can take a informed decision, right? Preferred place of care. Would you like to die at home, or would you like to be in an institution where you're cared for? We now, a lot of palliative care specialists say home is the best place to die, but we also have to remember, like I said before, dying is important for the people who are left behind. How they die is important for the people who are left behind. So in Bombay, we have small houses. Okay, the person who dies, traumatic or atraumatic, it doesn't matter. But for the caregivers to come back into that home and keep being reminded of that same, thing, that my father, my husband, my wife, whatever, has died in that room. A lot of them leave their houses. It's so traumatic for them. So let them take that decision that, okay, your patient is going to pass on. Would you like to pass? Would you like for them to pass at home? Would you like them to be in an institution? In an institution with advanced care planning, that do you want resuscitation, do you want to escalate to the ICU or not. We don't have a do not resuscitate per se in India, please remember that. So we have something called a do not escalate plan. There are 9 things involved in that do not escalate plan, which includes feeding, hydration, antibiotics, resuscitation, CPR, only chest compressions. Do you want to give cardioversion? It's a very detailed form where you explain to them what all do you want, what all do you not want to escalate. So have that discussion with them, give them a safe and secure place with preferred support system. I want my son with me, but I don't want to see my daughter's face. It's up to the patient. Okay, we are not going to sit and counsel them at that point when they are dying. We have opportunities to counsel them before, but not in that moment. The caregivers have to feel supported, involved, empowered, and satisfied. Healthcare staff has to feel confident and have a sense of teamwork. If one person feels that, oh, you're killing the patient, and the other person feels, no, you're doing a very good job, we have to do this because the patient wants it, there is conflict. Okay, so we have to all be on the same page. The nurses, the doctors, the ward attendants, the caregivers, everybody has to understand what we're doing. Continued communication throughout the process, so psychosocial support to the patient, to the family, and the caregivers. Meeting special family requests. Sometimes they want, certain religious, spiritual, or cultural things. Some people want that Ganga Jal to be put in the mouth, before the patient has passed away. Some people want certain prayers to be said, some hymns to be chanted. Someone wants a photo of their God to be kept besides them. So whatever it is, grant them that, right? Now, what are advanced care directives and living will? So, advanced care directives are exactly this. If we have had sufficient time to counsel them, unlike telling a patient, oh, you're going to die now, ये करो वरना ये हो सकता है. It's if you have only one conversation with a patient, they feel pressured, they don't have sufficient time to make an informed decision. We may not have sufficient time to sit and talk to them and help them make an informed decision. We may not be able to give them all the information that they need. Whereas if we counsel them right from the beginning, that okay, disease may go in this direction, this may happen, they have the time, they also feel a little calmer, they feel more empowered. So these are called advanced care directives. Simple thing, do you want a rise tube or not? So when the patient comes to us, we can see the patient has dysphagia. We start talking to them and telling them that look, at some point this may get worse. You may need support with your feeding, with your hydration. Would you like to have that? 90% of our patients end up saying no. The next visit, the caregiver asks us, पापा तो कुछ भी खा नहीं रहे हैं. Can we do something? आपने last time वो ट्यूब की बात की थी, आप फिर से बात चलाएंगे क्या? We talk to them again. Usually the patient again says no. But we have time. We come back for a third visit. The patient is not so good. We counsel them that look, if you want to put a rice tube, we have this window. Later on, if the disease grows, you may have obstruction. We may not be able to put it. You may need to, undergo a minor procedure. You may need a peg. Somewhere they've had enough time to come to terms that they may need this, and they get it. So, other advanced care directives, do I want to be, like I said, how much of escalation of treatment do I want at the end of my life? Do I want antibiotics, or do I want, am I okay with the patient getting fever? Is the patient okay? Patients say no, we want antibiotics, we continue that. There are some patients who say no, whatever it is, abhi mujhe kuch bhi nahi chahiye. Do the patients want resuscitation or no resuscitation? Do the patients want ventilation or no ventilation? Even in ventilation, do they want intubation? Do they want, after intubation, the period is over, do they want to go for a tracheostomy or not? You have to have all of these very, very elaborate decisions as part of advanced care directives. So when we know that the patient is sinking, what we do as a department is we have a family meeting, which goes on for almost 45 minutes to an hour. We tell them you bring all your relatives, because usually there is some son or daughter who is abroad, somebody is married and gone to another state, somebody is somewhere for work, parents are here. Get everybody together, everybody be on the same page, because I'm sure everyone has had this personal experience also. Diseases like this, problems like this, they cause families to break because there's one decision maker, somebody is taking all the decisions. Eventually patient is going to die. Some brother or sister will come from somewhere and say ye kyun nahi kiya, tumne to theek ख्याल ही नहीं rakha. We don't want that to happen. So a family meeting for discussion of advanced care directives is very, very important. Now, what is a living will? So we've started a living will clinic at Hinduja just recently. Initially, if you look at what a living will entailed, living will is when a patient knows ki, okay, I'm going to die. Patient himself is saying ki, do these things for me, advanced care directives, but formally they put it in a will, just like you have a financial will or a legal will for your property, for your assets. Same way, this is a medical living will. I do not want to be on a ventilator. If this happens to me, please bring me to the hospital. But do A, B, C, D, E with me. Do not do 1, 2, 3, 4 with me. They create this living will with their doctors. It is a multidisciplinary team again that tells them these things can go wrong. These are your treatment options. This is what you want. It is a very, very highly informed decision that can be made. The copy of the living will is given, it is notarized and now given to the patient, the primary physician, the palliative care physician, the hospital where they want to be treated or where their treatment is going on. One to the notary, the district magistrate. You're supposed to give it to the district magistrate, and one copy to the caregiver. So that is how it is moved. The district magistrate, initially you needed the district magistrate to be involved in the living will, but from Jan 2025, we have made inroads with the Supreme Court. So now you only need to have a notarized copy, which is just given to them. They are not involved, the district magistrate or the legal departments are not involved in your decision making process. Okay. Now, what is bereavement support? So, okay, the patient has now passed on. What next? What about the people who are left behind? Like I said, a lot of our patients are young adult males. They leave behind a lot of dependents, wives, children. Financial support is not there apart from the grief that you're already feeling. So, identifying families and caregivers who are very likely to need bereavement support, all the bereaved families to be part of bereavement support groups run by medical social workers, volunteers, in our case, the nurses and our counselor, Seema. We are holding it together. All bereaved patients with bereavement symptomatology, anxiety, depression, emotional distress, or somatic symptoms. Grief, there are 5 stages of grief. If you've read about the famous paper by Elizabeth Kubler-Ross, 5 stages of grief: anger, denial, anger, bargaining, depression, and acceptance. And you can go through, they come like waves. You can have either or, but there are always 5. You will go through all 5 before you reach acceptance. Nobody is going to reach acceptance at stage 1 and be like, हाँ वो तो चल गए, चल बसे. It doesn't work like that. You will be angry at some point. You will be in denial at some point. These are going to happen. So that grief counseling is very, very important. The stress, now caregivers undergo a lot of stress. Please remember, they are going through the illness of the patient, going through the treatment plans, the palliation, everything with the patient. But at the same time, they also have to continue living their so called normal life. They have to go to work. They have to, have their salary come home so that they have their paycheck to support the family. They have to go cook their food, feed the children, keep up social appearances. They have to do all of that. But at the back of their mind, there is so much stress, which in that high adrenaline, zone is not seen. And we usually see it 6 months after the patient has passed away. They will start developing, say, acidity, a lot of them high blood pressure, hypertension, diabetes because of stress. We have seen heart attacks, in senior people. They come, and it is because of that intense period of stress that you've been going through, but you've been powering through it. So, somatic symptoms are very, very real because of stress. Okay. So, that is something we need to. So, now if they're going to be seen 6 months after, how long are we going to support them? How long will we carry forward this bereavement? As a department, since we do regular telephonic follow-ups for our patient, we follow through for bereavement usually the day the patient has passed, because we have a relationship. They call and tell us, or they send us a message. Most religions finish their rituals within 15 days. So we touch base and 15 days, ask them if they need anything. Again at 1 month, 3 months, 6 months, 1 year. So we follow up with all our patients for at least a year after the patient has passed away. Okay. Sometimes they may need prompt psychiatry referral, pharmacotherapy interventions. To those complex bereavement symptomatology, refractory to counseling and psychotherapy based treatment. So, if you are not getting better with just counseling or support groups, we may need psychiatric referrals and medication. What is caregiver distress? There are umpteen number of papers that have been written. These are some of the important ones for caregiver distress. Again, a topic very, very, very close to my heart, because I'm sure even though we are doctors, we've all gone through something like this with somebody we love in our own families. It may be your grandparents, parents, spouse, child. There will be a caregiver burden on all of us. So that is what we talk about. I already discussed it briefly earlier, but caregiver distress is a very, very real phenomena. Like I said, you are going through everything that the patient is going through, but you have to live your so-called normal life also. It is a lot of strain on the patient, on the caregiver. Just a simple asking them when they are in your OPD, कि आप कैसे हो? How are you today? Are you okay? And a lot of them just break down, you know. You can try it yourselves if you haven't already. Just ask the person accompanying the patient, ki, how are you? Nobody checks up on them. So that is a very nice habit to have. They also, it helps you build trust. It helps you build a connection with the caregiver also. Yeah. So in conclusion, integrating palliative care soon after the diagnosis of advanced cancer can be beneficial in the following ways. Okay? Bridging the gaps in cancer care by providing both anti-neoplastic and supportive care together, hand in hand, which is why we say palliation. Introduce palliative care at diagnosis. Communicating realistic prognostic information. So a lot of times, given the kind of patient load that we have in your OPDs, you may not have the time to sit, like we do. So we would sit for half an hour, break bad news. We would sit for 45 minutes and have that end of life discussion. You would not have that kind of time. So please, just share the load with us. Empowering patients and their families for shared treatment decision making about whether to receive symptom directed care or cancer focused therapy. This is a very, very important thing in our scenario. If you've seen, so something I believe in, okay, is there are a lot of cases. If you see, patient ne doctor ko maar diya, mob has come, they've hit the patient. Or if you talk to both sides, the doctors feel, Ari, these patients come to us so late. What are we going to do? They take this Ayurvedic therapy, homeopathy, and then they come to us. They've come to us with end stage cancer. What can we do? And at the same time, if you talk to the patients, they say that the doctor doesn't talk to us. The doctor is not telling us. They have just come and told us ki ye hai, ye karo, and that's that. So my personal belief is that communication on both sides needs to be there. We need to help them be in charge of the decisions that they want to take. Give them the information. Talk to them compassionately. And you're not, a lot of these problems are going to come down. Okay, encouraging end of life discussions. We are very scared to have end of life discussions when we are treating physicians or surgeons, because the patient comes to you with a lot of hope, right? They want to get better. If they don't, if you tell them the truth, also they'll go to somebody else, they'll go to somebody else. They want to hear certain things. So, giving them, at least our job is to give them very realistic advice. Tell them, okay, this is end of life, and give them their treatment or palliative options then and there. Deciding preferences for care, providing better quality of death, quality of life and quality of death, both are equally important. Mitigating inappropriate costly investigations, cancer treatments, and hospitalizations that are unlikely to benefit the patient and inconsistent with goals of care, right? Because financial burden also, there are patients who, when they come to us, we realize they have mortgaged their land, their homes, their properties. They've got young kids now where the patient is going to, pass on, but there's nothing left for them to move on with their lives for. So that is also an important decision for them, for us to help them make. Improved quality of life and satisfaction. So even after the patient has died, a lot of majority of our patients are still touching base with us. They are still talking to us, which is very rare. They are not angry with the hospital. Ki, "Arey, patient to mar gaya." Arey, helping them through their illness, helping them, counseling them makes that difference. So this is our Department of Palliative Care. That's me in green in the center. Pink is Seema, our counselor. She's our psycho-oncological counselor. And Sister Swati and Sister Priyanka. Sister Swati is in between next to me. She is our senior nursing officer. She also helps with, since we wanted to take this palliative ideology to the hospital, I like to call it an ideology, like a lot of other ideologies going around on WhatsApp nowadays. She helps us with lectures for the nurses. So for nurses also to identify wound management or mucositis, these things, we can help them. Just, it's very easy to manage these things if you know how to catch them. So first thing is identification, then you come to treatment. So the nurses, every month, all our nurses have had lectures. They have understood what palliative care is. For the last 1 year, we've been doing that. Palliative care lectures and introduction to palliative care has also been included as part of your HR induction program, if any of you have had it already. So that is something we have started doing. This is for our department, what we've been doing since inception, Jan 24. So we've seen about almost 1,300 patients in the OPD last year. We are reaching that number. This is the last 6 months data for 2025. IPD patients, we see patients who are referred to us, but you'll also see our team on rounds. And a lot of times they ask us, what do you all do? So this is what they do. They counsel the patients. They tell them what to expect, not just treat the symptoms. Symptoms also can be treated by them, but more important is counseling. So the daycare patients are forewarned or counseled or told earlier on that okay, you may have vomiting, you may have hair loss. Don't worry, it's okay, it'll come back. Just holding your hand and talking to them about all these things is very, very important, because when it actually happens, it's not a shock. And they're not, that anxiety doesn't compound the total pain that they would go through. Procedures, we do rice tube insertions, we do wound management, fungating wound management. Sorry? Yes, a lot of wounds that we get have, they are very dirty, they have maggots, infected. So we help them remove them, teach them how to care for them. Uh, Telephonic follow up, I'm very particular about this, because a lot of our patients, they have already been at stepladder stage 2. So when we get them, they have already received tramadol, tapentadol, buvalar patches, all of that has already been done. So by the time they come to us, they are at level of step 3. They need morphine, they may need fentanyl patch if they're affording. So when we provide them with morphine, we are very particular about how we give it, the dosages in which we give morphine. Morphine is also a drug that, if given in overdose, could cause a lot of complications, including drowsiness, respiratory depression. In that stage, a lot of patients, like I said, we as Indians love to feed our patients. So aspirations are very, very common, because they'll try to feed, even though the patient is drowsy, अरे वो उठा ही नहीं है उसको कुछ खिला दो. In that situation, we don't want to have an adverse event. So, whenever we counsel our patients, whenever we put our patients on morphine, we counsel them A, on all the side effects. B, we tell them to reach out to us we give our numbers out. We tell them to reach out to us within 48 hours of starting morphine and give us feedback. Okay, how was it? And within 7 days, come back. We give them only 7 days worth of medication to begin with. In 7 days, they touch base back with us whether the pain is, better or worse or no change. Whatever it is, we titrate the medicines and then we continue with them. We give them morphine long term for a month. Patients who are coming from UP, as a policy, we give them 2 months worth of morphine. Most of them come back to us after two months to receive their, collection of morphine. We are very, very particular also. We ask them to bring their empty strips so that we know how much has actually gone to the patient and not gone. The morphine that is left over, suppose patient has got 1 month's stock of morphine and the patient has passed away. They come back and they return it to the pharmacy. So we know that there's no, hanky panky happening with the drugs. So we are safe on that account. So telephonic follow-up, that is for morphine, of course, but also weekly follow-up goes out to each patient and their families. How are things? Have symptoms worsened? Has anything new come up? Are you okay? Just a simple call goes to everybody. Every Saturday, our department makes those calls, apart from the other calls that come to us in emergency or whatever else. Now, since we don't have a home care team for the hospital, we tie up with two home care NGOs who provide free home based palliative care to our patients. We refer them to them. They give us feedback also on how the patients are doing. So there is a good comprehensive like network that we have formed. If the patient is from out of town, if they're going to UP, or majority come from UP, so we connect them with our palliative care partners. Unfortunately, in UP, because it's a very, very big state, we only have palliative care centers that provide morphine, or some of them even don't provide morphine, but palliative care centers or practitioners only in major cities. So Lucknow, Kanpur, Banaras will have palliative care physicians. But if you look at internal, like smaller towns, villages where a lot of our patients come from, it becomes difficult to connect them there. So, for all our patients, apart from these home care teams or palliative care referrals, we also ask them to keep a local GP or a doctor or a family physician in the loop in case there's an emergency at home. You can call us, but we are not seeing the patient. So we would direct you that, okay, this is a time, please call your local physician. They would come and at least give you point of care, in your homes. If there is a death, they would be there to certify the death, because that is another very, very big problem that happens. Death certification. People don't come up because, अरे आप treatment तो वहाँ ले रहे थे, वहाँ जाके ले लो certificate. Things, very petty things like this do happen. So we ask them to keep them also in the loop, at least have a monthly visit, particularly towards the end of life, when we know the patients are sinking. Bereavement follow-up, we have 120 families in 24, 252 families that we are following up with now. We've had a lot of awareness and staff sensitization workshops. ESAS is a scoring system that we use for checking the symptom burden of the patients. If you've seen our forms, we have an ESAS form. If you see even our OPD notes, We have a stamp for ESAs. So we look at, you all must have seen it. So we look at all the symptoms. There are about 10 symptoms that we focus on, including pain, nausea, vomiting, restlessness, sleep, no sleep, insomnia, all of these symptoms together. So we have a holistic understanding of what the patient is going through. So we check ESAs for all our patients. We run a counseling OPD for patients who specifically need counseling. They come on Tuesdays and Thursdays. Monday, Wednesday, Friday was my OPD. Now, from October 1st, we also have Dr. Shiva who's joined us full time. So our services will be available full time to the hospital. From 10 to 6, we have our OPD and doctors and nurses. Everybody will be available. 2024, since we were new, we also had, little erratic OPD timings. Sometimes we'd be there in the morning to, focus on the oncology team, sometimes the surgical team later in the evening, so that patients could be seen at all times of the day. But now that we have also comprehensively developed into a department, we will be present every day between 10 to 6. Saturdays, our team is there 8 to 4. So there is a doctor on available every day. Any patients that need help, any referrals in the ward, please do let us know. We are more than happy to reach out and help. Counseling for the caregivers, as you can see, we had about 1,800 patients last year, but in the last 6 months, we've already had 1,000 patients. So hopefully, we should have more this year. And academically, last year we've just done our data collection. This year, we plan to present at our national conference and a couple of other conferences that we have, coming up in February and March next year. So that is what we have done as a department. This is what we have done. Highlights, of course, for us personally, we do total pain management. Like I mentioned, it's not only the physical pain that we cure pharmacologically, we also look at psychological, social, and spiritual pain and help patients run through them. Follow up for narcotics, like I just mentioned, I don't want somebody dying of aspiration or respiratory depression, at home because of morphine. So we have had zero morphine side effects so far, which is something we are very, very proud of. Wound management. Now, for wound management, large wounds that come to us, disfigurement, uh, you know, wounds with maggots, of course, we do manage them as we do. But something different that we do is we don't use betadine, we use metrogyl. There are two papers that I've quoted for this. For cancer wounds, metrogyl works better. So we have a system as to using metrogyl ointment and metrogyl liquid, the IV that we give. Also, you could also use crushed metrogyl tablets for the same. Mucositis management, you all must have seen the magic mouthwash that we prescribe. That again is a formula that has come from TMH. So that is what we are using here. Breaking bad news, first visit when we are told that, this is the end of the line. If we have to convey that to the patient, we use something called a spikes protocol. Psychological counseling, we have a dedicated counselor for palliative care where we do early palliative care like we do in the wards, in daycare or in the economy wards. If you have seen our team go around, this is what we start with, just slowly easing them into, comfort, taking care of their anxiety, their depression. Family meetings for end of life discussions, ensuring every single stakeholder in that family is on a call or in our OPD. Bereavement, telephonic follow up with all our patients, bereavement follow up with caregivers, as I have already elaborated earlier. So, to conclude, this is again a quote by Dame Cicely Saunders, who is the founder of palliative care. You matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but to live well until you die. And that is the motto of our palliative care department. That's all from me. Thank you.